Hi, everyone. Thank you so much for being here. I am House Minority Whip Rachel Roberts from the great Commonwealth of Kentucky, and I'm really thrilled that we're having this panel discussion today. It's my understanding that this is the first time there has been a mental health care coverage conversation at NCOIL. I think we are all aware of how timely and important this conversation is, and I'm really grateful to our speakers for being here today. We have a really phenomenal panel of speakers here to discuss this and our ongoing efforts to achieve parity in mental health care in the country. And as we all know, there's been an intense interest over the last few years or so in addressing our nation's mental health crisis. And one problem area that both lawmakers and advocates have identified is unequal coverage between mental health and physical health, and it's one of my champion causes to make sure that we try to move the population so that we start thinking of mental health as just as important as physical health, and we approach this from a much more holistic standpoint. In 2008, Congress passed landmark laws requiring mental health parity, but compliance and enforcement have been very difficult, which has led Congress and states to try to fill those gaps with different types of policy solutions. In your binders on page 377 and on the website and app, there's a bill that I am sponsoring in Kentucky that mirrors a bill my friend, Representative Michael St. passed in Colorado, and she'll speak to here in just a moment. It would require health plans to cover an annual mental health wellness examination of at least 45 minutes to mirror what happens in the physical health side, and that is performed by a mental health professional. And that coverage must be no less extensive than the coverage provided for medical and surgical benefits. It must comply with the Federal Mental Health Parity and Addiction Equity Act of 2008, a law which we will hear a lot about today, and not be subject to co-payments, co-insurance, deductibles, or any other co-sharing requirement. The idea here is that we allow people to have a once-a-year mental health checkup, that they have a provider that they've already developed a relationship with so they're more comfortable talking about it, so that states like mine that have mental health care provider shortages have a way to entice practitioners to come to the state with a built-in client base and a start to their practice. After our session today, I'm very interested in perhaps using that bill to develop some type of NCOIL model act or resolution focused on mental health care parity requirements. Before we hear from our speakers, I'd just like to recognize my colleague from Colorado, Representative Daphne Michelson-Janae, for some brief remarks, as I know you are also very interested in this issue. Please go ahead, Daphne.
Thank you, Representative Roberts. It is an honor to speak before you today about this issue, which is exceptionally dear to my heart. And I came into the legislature with one mission, and that was to stop suicide. My son, when he was 9 years old, attempted suicide, and that changed the life of our family in a very dramatic way. And we have been working on, as a family, and I in the legislature, stopping suicide from the moment I got there. But how do you stop suicide? Let's think about it from a heart attack perspective. Let's say we're trying to stop a heart attack. If you go to your doctor, and this is what our system is today, if you go to your doctor and you say to your doctor, you know, I think I'm having some trouble with my heart, and the doctor says to you, yeah, I think you're having some trouble with your heart. Give me a call when you have a heart attack. That's our mental health care system. 57.8 million adults in the United States live with a mental illness. That is 1 in 5 people. Of those 5 people, over half of adults, 54.7%, do not receive any treatment for their mental illness. Why? Barriers to entry, barriers to treatment, fear, stigma, lack of knowledge. These are all the problems that we were having in our physical body when it was actually insurance companies who came up with the idea for an annual physical. It was about the time of the flu pandemic, about 100 years ago. In Colorado at the time, there were 300 doctors. You only went to the doctor if you were rich or dying. And insurance companies said, maybe if we teach people how to care for their bodies, they can maintain it and mitigate problems like mitigating a wildfire. And people started to slowly adopt the idea of a physical. Here we are 100 years and another global pandemic later, and I'm asking you to think about your mental health care in the same way you think about your physical health care. We keep saying through MAPIA and other factors, we keep saying that mental health care matters as much as physical health care, and then we do nothing about it. In our state, we're trying a model that is an annual mental health wellness exam that Representative Roberts talked about, and the legislation is in your books. And this will give people the opportunity to build a relationship with a primary mental health care provider. And you do it at different times in your life so that when you're a child, you have a child provider. When you're adult, you have an adult provider, and maybe you've just gotten divorced or you're about to get divorced and you don't want to get divorced, you can use a marriage and family therapist for your annual mental health wellness exam. Let's say you're skirting the concern about substance abuse. Not ready to say that I have a substance use disorder, but you can use a substance use specialist for your annual mental health wellness exam. Let's say you're a senior citizen that's dealing with loneliness. Geriatric providers will help you with your mental health wellness exam. This is a life cycle opportunity to take care of your mind in the way that you take care of your body. Thank you.
Thank you so much, Daphne. Thank you for being here. Now I'd like to introduce our panelists for today. Their bios are in the app. If you haven't downloaded the app, do so before you leave here. There's so much great information on all of the people who've given us our time. Our panelists today include Daniel Blaney-Cohen, Senior Legislative Attorney at the American Medical Association, Tim Clement, Director of Legislative Development at the American Psychiatric Association, David Lloyd, Chief Policy Officer at the Kennedy Forum, my apologies, David, Pamela Greenberg, President and CEO of the Association for Behavioral Health and Wellness, and Brad Lerner, Director of Public Policy and Manager of Behavioral Health and Enterprise Issues at Elevance Health. In terms of format, we'll hold all the questions until the panelists are finished, but let's go ahead and get started. And will help us with the time. I know we're running late. So the first question I have for our panelists, if I may, is going back to 2008 when Congress passed the Mental Health Parity and Addiction Equity Law. Oh, never mind, I have no questions. You may begin with your presentations if you would like. That's why Will is here to keep me on track. Thank you, Will. Please begin with your presentations as you like.
Hi, everyone. I'm Pamela Greenberg, and I'm the President and CEO of the Association for Behavioral Health and Wellness. I want to thank you for inviting me here today, and as with the other two representatives, thrilled to have a conversation about behavioral health. It is long overdue. Okay, that slide just switched without me doing anything. So our organization represents health plans, and our members serve in total about 200 million covered lives. And we work mostly at a federal level and exclusively on behavioral health, mental health, and substance use disorder issues. And just to give you a sense of, these are some of the priorities that we have in general. We're looking for public policy proposals that will increase both access and quality, look at prevention, as just been mentioned, and also trying to forward more integration in our system. My job today is to talk to you specifically about MAPIA, the Mental Health Parity, Addiction, and Equity Act. We can't say that, keep saying that, so we say MAPIA instead. So I'll just be giving you an overview of the law. And we, as ABHW, my organization, actually has supported parity since its inception. You may not know that the payers actually were very upfront and supportive of parity and worked with some of the organizations at this table. We were a member of a coalition for fairness in mental illness coverage that was actually helping write the legislation. And our member companies have worked very hard over the last 15 years now since passage to implement the law. We've done things like seen a wider variety of treatments are now available, also a wider variety of provider types that we're contracting with. As you may know, co-payments were equalized in the legislation, which in essence led to lower co-payments in behavioral health. Also, day and visit limits that existed before were eliminated. And as it says up there, lifetime and annual dollar caps were eliminated as well. And prior authorization, not eliminated, but definitely lessened as a result of MAPIA, especially in the outpatient space. Sorry. There was actually a mental health parity bill before MAPIA. You might not know that. It was in 1996. And that legislation only applied to mental health. Very key to know. So it did not apply to substance use disorders. And it did not require any coverage of mental health, but it did say that you can't have different annual or lifetime dollar limits on mental health than you have on the medical side. It also did have a cost exemption, so that if an employer's costs increased by more than 1%, their premiums, and you could show that, you could be exempt, you could ask for an exemption from the law. But that's really the first action at a federal level that we saw for parity was in '96. And then in 2008, the MAPIA passed. And that also, important to know, it did not mandate coverage. It said if you offer mental health and substance use disorders, that was key to bring in substance use disorders, then you have to treat things equitably comparing to medical surgical. It focused on two main areas, financial requirements, and those are things like your co-payments and your co-insurance and your deductibles. It applied to that. And then it also applied to treatment limitations. That would be any limit you have on the number of visits or your length of stay in the hospital. And it was typical to have those kinds of arbitrary limits in an insurance policy prior to that. The reason as insurers that we supported it was because we knew those limits were arbitrary and that one person might need 5 days and another person might need 55 days. And everybody was treating you were better at day 28 no matter who you were. And that was, as I said, very artificial. The one thing that was added in the rule was something called non-quantitative treatment limits. You will hear every speaker, I think, today talk about that, NQTLs. And those are other limits that were placed on treatment, mostly ways that companies manage the benefit, the way you pay a provider, or the amount that you pay a provider, your drug formulary, any kind of utilization management. Those things are all considered a non-quantitative treatment limitation, or NQTL. Those are also now, via the rule, included in mental health parity. I would think that's where we have the most discrepancy right now. The most confusion is related to NQTLs, and that's where compliance is the hardest to show. The other areas, it's much easier to show that you're complying with the law. The law applies to these lists. I don't want to read the slide, but it applies to all of these. I guess for some of you in the back, maybe I should because you can't see it. But group health plans, it applies to Medicaid, the Children's Health Insurance Program, non-federal governmental plans, that's like a state university. You probably know that better than I do. And also federal employees have a parity benefit. It does not apply to Medicare. So that's something also to keep in mind. There were many things that MAPIA did. It created 6 classifications of benefits, and if you offered coverage in one, you had to do it in all 6. The 6 are outpatient and inpatient, both in network and out of network. So that's 4 categories right there. And then pharmacy and emergency room coverage were the others. And again, so you had to provide coverage in all of those 6 areas. It required an out-of-network benefit, so prior to MAPIA, not all health plans were offering out-of-network coverage for behavioral health, and now it required it if you had it on the medical side. It did allow for you to manage the benefit, and frankly, that was in lobbying for the bill. That was one of the things that we would talk about, is that managing the benefit would be able to keep the costs down. You know, governments always have to consider how much legislation costs as well. It required that you disclose your medical necessity criteria, and also a reason if you were denying care, the reason for denial to be sent to the patient. Small employers were exempt. It also had a cost exemption which has since been removed, but was in the bill. And then you can see some different studies by GAO, the General Accounting Office, and also a compliance report, and consumer assistance working with states, and regulations, of course, to follow. Where the mandate of coverage for mental health and substance use disorders came in was actually through the Affordable Care Act. So the Affordable Care Act, as you may know, created 10 essential health benefits, and mental health and substance use disorders were in that list of essential benefits. So when you combine the Affordable Care Act saying you have to cover mental health and substance use disorders, and then MAPIA, which says you have to cover it at parity, that's how we basically get the mandate for mental health and substance use. And also the Affordable Care Act brought in MAPIA applying to the individual market and the exchange market. Then in 2016, we had something called the 21st Century Cures Act, which also talked about parity, more from a guidance and compliance perspective, both guidance to regulators in terms of things that they should be doing, but also guidance to plans in terms of how they should be implementing parity. And I think the biggest thing on this slide and the next slide is the requirement for illustrative examples of non-quantitative treatment limitations, and also description of violations for things that the regulators found when they found a problem, get that information out there. And I highlight these because these are things that we're still seeking to this day from regulators, and that's a big ask of ours, is give us more information so we can make sure that we're complying correctly, because there is a lot of back and forth that happens now in an audit. So some of that information has come from the regulators already, but we believe there still needs to be more, and we want to learn from people's mistakes. That's why we would like to see descriptions of the violations as well. The Department of Labor puts out a self-compliance tool. Well, it's already out, and every 2 years they're supposed to update it. They're, I think, a year or so behind right now, so we are waiting for an update in that area. And of course, they're supposed to be, and hopefully they are working with all of you in terms of compliance with parity as well. And then a few years later, the Consolidated Appropriations Act of 2021 also discussed MAPIA. And in there was a certain complex approach that was required. Tim may talk more about that, for the NQTL analysis. So it got a little bit more into the nitty-gritty of how you had to do your parity compliance analysis. It also required the federal regulators to issue more regulations related to MAPIA. That was supposed to be done within 18 months, so they're about 1 year overdue, but the bets at the table are that that regulation will be coming out in the next few weeks. We don't know for sure, but that's what we are thinking. And then it also had some of the same language in the bill I just mentioned, the Cures Act, in terms of releasing de-identified information and illustrative examples. And again, we really just think that this would help in the compliance process. And that is it. This is my contact information, and I will turn it over to Tim.
Okay, thank you, Pamela. And so my name's Tim Clement. I don't have any slides, so I'm just going to talk through. So just to give you a little background on myself, I'm the Director of Legislative Development at the American Psychiatric Association. So what that means is I get into the weeds on issues related to mental health and substance use disorder, and then I write state and federal legislation to address those issues, and then work with state legislatures and Congress to get those things moving, passed, and signed into law. Most of the legislation I've written since I've had this job is related to insurance coverage for mental health and substance use disorder treatment. And before I had this job, I worked at the Kennedy Forum just like David Lloyd does, and back in 2015, I had a project where I had to look into, find every state law related to mental health and substance use disorder insurance coverage, analyze it, summarize it, put it on a website, and then also find every piece of legislation in all 50 states that have been introduced between 2009 and 2015 about mental health and substance use disorder insurance coverage, analyze it, summarize it, put it on a website, and the website's called Parity. So I give you that background in the sense that I have a lot of familiarity with the state laws that relate to mental health and substance use disorder insurance coverage, their interplay with the federal parity law, MAPIA, and what the evolution has been. So what I'm going to do is I'm just going to tell you sort of what's happened at the state level and talk a little bit about what happened in Congress with what Pamela mentioned with the Consolidated Appropriations Act, but just give you background on state legislation and state laws about mental health and substance use disorder insurance coverage before MAPIA, and then what that's looked like since then, and then maybe what it's going to look like in the future. And I think David will talk a little bit more about that. We talk about parity before, and as Pamela mentioned, Congress addressed the issue of parity in a very minimal fashion back in 1996. The co-sponsor of that legislation, the late Paul Wellstone from here in Minnesota, said, "We didn't get half a loaf, we got crumbs." So that law back in 1996 really didn't do very much, and it wasn't until 2008 when MAPIA passed that you really saw a very transformative event. So before that, before 2008, it was largely left up to state legislatures to determine what the landscape for mental health and substance use disorder insurance coverage, what's that going to look like. And so before 2008, a lot of states, pretty much almost every state in the country except Wyoming, passed legislation that had some level of specifications for what behavioral health insurance coverage is supposed to look like. And while some of those laws had the word parity in them, virtually none of them actually were parity. What they were doing is they were establishing a sort of a minimum level of mandated benefits or mandated offering of benefits. And the way that usually manifested itself would be they would specify that insurers must cover 30 days of inpatient treatment and maybe 45 days of outpatient coverage. And what those essentially would operate as would be the cap. So once you get your 30 days of inpatient treatment, if and the state has a law as such, that's it, no more. Even if you're in dire crisis and you need considerably more inpatient care, you hit your cap, no more coverage. Or you get your 45 days, once you get your 45 visit limit, you reach that, no more, won't pay for it anymore. So that was really what states were doing in the 90s into the early 2000s, was establishing what basically the ceilings would be, and then also maybe addressing the annual dollar limits or the copays and cost sharing. A lot of times the cost sharing and copays, they would specify that it had to be on par with what you do for medical and surgical, but then there'd be like, say, a $5,000 annual limit. Or there'd be a separate deductible for mental health or substance use. So you met your regular deductible, but then you've got another deductible for mental health, and then another deductible for substance use disorder. And one thing that's I think you'll find shocking today, given the opioid epidemic and how many people die every day from that, and given but back in the early 2000s, a lot of these laws explicitly exempted substance use disorder. In other words, they said, this is about mental health coverage, and this does not mean substance use disorder. That is not, we do not intend to cover that and have that be on a minimum level. So a lot of times, if you're seeking substance use disorder care, nothing. You couldn't get anything because that was often explicitly carved out and not covered by these state laws. So then, 2008, as we've heard, MAPIA took place, and essentially what that did is that made most of these state laws with their numerical limits on how many days of coverage you would get, how many outpatient visits you get, some of the cost sharing stuff. It made them largely irrelevant because due to we won't get into the math test that exists in MAPIA, but essentially now you can't have limits on inpatient days and outpatient visits and comply with MAPIA. So all of those state laws, and if you look in your insurance codes, you'll still see a lot of those things are on the books still, where you'll see a 30-day inpatient limit, 45, or 50-day visit outpatient limit. So what MAPIA did is it made it essentially so that now we do have parity. Now you do have to have things on par with medical and surgical. And as Pamela mentioned, those quote unquote non-quantitative treatment limitations like prior authorization or formulary design or how you design your network, those things have to be comparable to and applied no more stringently than how they're done for medical and surgical. So that's really where the landscape has shifted since 2008, and really it's only been in the last 5 or 6 years. The focus became less on mandating levels of coverage, because now that's not really necessary because of MAPIA, but it became more on really helping implement MAPIA and also filling in gaps, because the way MAPIA works is it sets the floor, but states can go beyond that. And for instance, like having an annual well check or something like that, you can, and David will talk some more about some other things that states can do. So MAPIA is the floor, and it is a much higher floor than what used to exist. But state legislatures, they still were busy on this topic over the last 5 or 6 years. Starting in 2017, but really 2018, state legislatures started passing laws that required insurers and sometimes Medicaid managed care organizations to do these comparative analyses and submit them to the regulator, the state insurance department or the state Medicaid agency, showing how it is that they comply with the very complicated non-quantitative treatment limitation rules within MAPIA. And I will say that. It's a complicated and obtuse term, non-quantitative treatment limitations, but if you think that's complicated, if you were to read the actual language in the Code of Federal Regulations, I would recommend that you don't read that. It might give you a seizure. But what states started doing is they started passing these laws starting in 2018 saying, okay, you've got to do your comparative analysis, prove it to us. Prove it to the regulator that you're in compliance with these very complicated terminology in the law. And states started passing that. And then, so, Pamela mentioned the Consolidated Appropriations Act 2021. State legislatures actually informed Congress. So in 2020, the end of 2020, that's when the Consolidated Appropriations Act was signed into law by President Trump. It was, now the federal law, MAPIA, requires every insurer and every group health plan in America to do these comparative analyses and submit them to the regulator upon request. And so when the ink was dry on that bill in 2020, 13 states had already done that. And the language in those state laws was identical to what was in the federal amendment, was now in the federal law. And since then, it's now over 20 states now have an annual reporting process where insurers have to submit, or Medicaid managed care, to the state regulator these comparative analyses, and the United States Department of Labor collects them from group health plans every year. So a question you need to ask is, okay, 6 years ago today, there was not a single insurer or group health plan in America that had to do these comparative analyses. A little more than 3 years later, everyone had to do it. So you wonder, how could that, you go from 0 to 100, in like 3 years? That doesn't usually happen. And what the argument that was made, and I was one making this argument, so was David and Daniel, these non-quantitative treatment limitations, they're really complex. And the state investigations, state market conduct examinations have looked into this. They've been finding some problems. And if you're an insurer, how could you know that the way these things operate are comparable to and applied no more stringently unless you did your own comparative analysis? How would you know? You couldn't. It's impossible. And that was very persuasive to state legislatures and members of Congress, and that's how things changed so quickly. So now the law has really been transformed so that there's a prove-it standard. There are not many laws where you have to prove that you follow, like there's a part of the law that says you have to prove that you follow the rest of the law. But that's how MAPIA works now, and that's because, I think state legislatures and Congress recognize that we have a huge crisis with mental health and substance use. I mean, over 420 people die every day from an overdose or a suicide. So state legislators and members of Congress wanted to act, and this is how they took action, and it was very swift and dramatic. And so now we have a changed landscape, but there's still plenty of things that state legislatures can do. The work isn't done. The Congress amended the law, state legislatures led the way, directed Congress how they should amend the law by passing their own laws, and then they did. But now there's still things that can be done just beyond, checking for compliance with the existing law, and I think I'll pass it off to David because I think he has some good ideas on that.
Well, thank you, Tim. Thank you for having me here today. David Lloyd, I'm Chief Policy Officer with the Kennedy Forum. Our organization was founded by former Congressman Patrick Kennedy, who is actually the author of the Mental Health Parity and Addiction Equity Act when he was in Congress. And so much of our focus in the 15 years since passage of the law was making sure that the law is fully implemented and enforced, and we're still doing that today. The Parity Act has been transformative, as Pamela and Tim have gone into, but there's still a ways to go. Health insurance coverage prior to the Parity Act was really non-existent for many Americans prior to the law, and there's still a number of areas where we need to address both using the Parity Act, but also there are issues beyond what might be the direct scope of the Parity Act, because it's really a non-discrimination law. And like with other non-discrimination laws, it doesn't accomplish all the goals that we might want by passing the non-discrimination law. We need other tools to address needs across society. So just one example of kind of the extent of the need that still exists, in addition to the more than 100,000 individuals who are dying of overdoses every year in the country, which has increased dramatically during the pandemic. Right now, about 5% of commercial reimbursement is on behavioral health, so mental health and substance use services. McKinsey recently estimated that about 15% of the global disease burden is associated with mental health and substance use. So there is a gap there between kind of the 5% of reimbursement and the 15% of what the global disease burden for these illnesses are. And we need to work to shrink that gap. And parity is an important component of that. And part of what's under the Federal Parity Act, which frankly has not, regulators have not done a very good job up until this point in addressing, our reimbursement rates for providers, and also which directly affects network composition and network adequacy, whether providers are in network. Just kind of one example of there's often disparity between in-network usage and out-of-network usage for mental health and substance use disorder care. And there was a landmark study a few years ago by the research firm Milliman that found that about 1,000% of children needing mental health visits, 1,000% more often had to go out of network than for the same physical health care. So it was a 10 times disparity, meaning that the in-network access to care for children for mental health was simply inadequate, but they were finding out-of-network providers who they would go to. That's roughly double what it was for adults. So for adults, it was only 5 times more often than they had to go out of network. There was also a recent Oklahoma study showing that, at least in Oklahoma, 2/3, health plans in Oklahoma, 2/3 of psychiatrists and substance use disorder treatment providers weren't contracted with. So that meant only 1/3 of providers were contracted with. So all those other providers were out of network, really resulting in not enough in-network access. But in many, but there was out-of-network providers available to be contracted with. And in a recent survey, only 31% of employers, were satisfied with their employees' access to behavioral health services in their health plan networks. So there is still an enormous problem, and a lot of it has to do with frankly, with reimbursement. And that directly leads to in-network availability of services. We certainly need more providers overall, but this is something that the Federal Parity Act can get at, and reimbursement rates are considered a non-quantitative treatment limitation. And more states are looking at reimbursement rates as an important contributor to the availability of in-network services. With regard to the Federal Parity Act, Tim noted that about half of states now have these requirements in place that plan to submit their parity compliance analyses. That should frankly be all states. So the half of states who haven't done so really should do so, and they should regularly be performing parity market conduct examinations So if they're doing a market conduct examination, parity should be a major component of that. A number of states have incorporated that requirement into their law. Illinois has done many market conduct examinations over the last few years and issued quite substantial fines for parity noncompliance. Only a handful of states, roughly a dozen, have ever issued parity fines. And given the types of violations that we see across the country, that means 35 or so plus states really have not honestly are doing what they should be doing in terms of having active market conduct examinations. And that doesn't even get into Medicaid. The Consolidated Appropriations Act requirements federally don't apply to Medicaid managed care plans, and this is taxpayer dollars that Medicaid managed care plans are using. And so it's important to make sure that they're parity compliant. So states can apply those same requirements to Medicaid managed care plans, make them demonstrate their compliance, and really many states have not honestly been doing what they should be doing in terms of oversight of taxpayer dollars in Medicaid managed care and CHIP. So there are also some other tools outside of the Parity Act. The parity is not a panacea that solves all problems. There are access issues across the board. We also see that even the continuum of care for mental health and substance use disorders, in many states there are gaps, and insurance does not cover key parts of those continuums. Those gaps need to be closed, either using parity or other laws. We also need to make sure that behavioral health emergency services are being covered. So 988 is of new interest. The suicide prevention and crisis hotline, 988. Insurers should be covering behavioral health emergency services just like they cover physical health emergency services. And states like Virginia have actually just passed new laws mandating that. So I'll stop there and pass it over to my colleague, Daniel. There's still a long ways to go. There are a number of tools in the toolbox. Parity is one important one, but it's certainly not the only one. And with the engagement of insurance legislators and insurance committees across the country, we can really make progress in these important areas.
Thanks, David. We're going to go back to some slides here. Hold this. Can't figure quite out how to use these tools. My name is Daniel Blaney-Cohen. I'm a senior attorney with the American Medical Association. Among the areas I'm going to highlight, try to build on the discussion here. One thing I want to start out with is talk about the big picture. And one thing that I think is clear is probably everybody in the room. It's always weird when people are behind us. Everybody in the room knows somebody who has a substance use disorder or has received care for mental health, whether an acute situation or a chronic situation. And I think, and one thing to remind ourselves of is, the stigma surrounding mental health, I think, has gotten better over the years. I can think in my own family, when people started to get care for mental health issues 20, 25 years ago, it was still pretty hush-hush. I think back to my parents, and my parents literally, we had a family member who went to go visit relatives in the country. And that was sort of the euphemism, back in the day. But so some things have gotten better. But I think the big picture is, things have the pandemic, and I want to start with that. I know everyone doesn't want to talk about the pandemic, or lots of us don't want to talk about the pandemic anymore, but it really put a focus on just the toll that mental health has on all of us and the importance of mental health and well-being. And in particular, on the effects on youth, and I'm so sorry. I wish there weren't so many stories and real-life events about young people taking their lives. I wish so many of us didn't have those examples in our life, but we do, and then there are solutions. We can't bring people back, but hopefully we can prevent more of those tragedies. And I think COVID really emphasized some of the big picture issues and the problems. But it's not just COVID, and I'm going to focus more on substance use disorders, which are an absolute disaster in this country. 100,000 plus people are dying every year. The numbers have not gone down. Maybe in some states they've plateaued a little bit. I don't think any of us see that as progress when hundreds or thousands in our states are dying. And everyone is preventable. with treatment, with primary, secondary, and tertiary prevention efforts. These are the things we have to do. The causes are different now than they were 10 years ago, but we still have to deal with this. And parity is one of the things that we'll talk about in terms of how. I want to highlight some things that everybody has talked about. Parity is a simple concept, right? That it should be no more restrictive in coverage for mental health and substance use disorders than any forms of insurance. And please, I've shared these slides with Will. I'm happy to share them with everybody here as sort of a take-home. But it has proven elusive for many reasons. And my colleagues have talked about some of them. I would say commitment to implementation and enforcement is the primary problem. And that's something where I think legislators have the role of oversight. Regulators have the role to implement. And I think that the partnership between the two is something that is one takeaway I hope everybody has today. And so actions, and that's part of the actions needed. Again, I want to emphasize the big picture. Over the last 10 years, that slide on the right, or that vote on the left, people who have a substance use disorder or mental illness don't generally get care. And there are many reasons for that. Those statistics largely haven't changed over the past decade. And the reasons for that, even though the Mental Health Parity and Addiction Equity Act is more than 15 years old, compliance has not occurred. And so I think it's a reasonable question to ask, why has compliance not occurred? We're not allowed to not follow the law in other aspects. So why are we not enforcing the law in such an essential area? And I have this on buprenorphine. Buprenorphine is just one of 3 FDA-approved medications to treat opioid use disorder. It's better. It has gone up a little bit, but it has not gone up as we would expect. The gold standard buprenorphine treatment, I'm going to talk about that a little bit more. Specific issues for substance use disorders, prior authorization. The AMA's position is that at this point in the epidemic, and we've been saying this for years, there is no justifiable medical or ethical reason to have prior authorization for medications to treat opioid use disorder. Medications to treat opioid use disorder are the gold standard for treatment. Delays and denials in care lead to people dying. Plain and simple. We can't sugarcoat that. Step therapy and fail-first therapies, whether we're talking about mental illness or we're talking about substance use disorders, again, these lead to delays and denials of care. At this point in the epidemic, and I think we're in epidemics of mental illness, a lack of coverage, a lack of treatment. We're in an epidemic of a lack of treatment, evidence-based treatment for substance use disorders. If there is a step therapy or fail-first protocol in place that goes against the recommendations of the physician, what we're doing is delaying and denying care. And it's going to cause those acute situations to become, or I should say, preventable situations from becoming acute and tragic. Network adequacy. We're not saying there has to be a psychiatrist on every street corner. We're not saying there has to be an addiction medicine or an addiction psychiatrist on every street corner. But if a young person or somebody now my age, if we go to the emergency room with a heart attack, I think it's a great example. We're going to get care. We're going to get an angiogram. We're going to be moved into the cath lab. We're going to be admitted. If we have to have surgery or another procedure, we're going to have follow-up. We're going to have a nurse case manager, give us one, right? I can think of my father, give one of those nice heart-shaped pillows. And there's going to be follow-up care. But if we think about mental illness or we think about substance use disorders, good luck getting an inpatient admission if that is what is recommended by the physician. Good luck getting intensive outpatient treatment if care can be provided in the community. These aren't issues of necessarily a lack of access, but they're a lack of commitment to provide that access. And I think that's an important distinction. I'm not going to read this. I just want to point out as you go through this, there are real-life consequences. When physicians and patients in the emergency department or in other areas can't get care, the last place they're going to look is the AMA website or the Kennedy Forum or other websites to file a complaint with your insurance regulator. That's hard. That's just not how people act. They're going to work their fingers to the bone trying to get somebody into care. These are just some examples, unfortunately, of people who were not able to do that. Types of violations found. I promise I will not read these, but the point is when regulators look for violations, they find them. And this is just a short list of those. That bottom one, failure to use ASAM criteria as required by statute. Here's one I think everybody here should care about a lot more. Many of your states have, by law, required the use of the American Society of Addiction Medicine, the preeminent addiction medicine society in this nation, required the use of those criteria to determine levels of care for that patient. That's required by law. And violations found by regulators of payers is that they don't use the ASAM criteria required by law. That should make you mad. And that's, again, something that happens on a regular basis. Quick look at Illinois, and I promise this will be quick. These are some resources that I wanted to provide to everybody. The DOL report that people mentioned is on the left. There's a link to that. The Justice Department has issued guidance that people who are denied medications for opioid use disorder, that is almost always a violation of the Americans with Disabilities Act. The Illinois Department of Insurance has done, and they're not the only state, but so there are states doing very good work to enforce the law. I'm going to talk a little bit about the Illinois DOI in a second. They're doing the work. Excellent job. In the top right there, that's it's a terrible slide because nobody can see it. It's worse than an eye chart. But it's an example of a regulation enacted in Colorado a couple of years ago following the law, and it basically says you have to measure the network. If you're not measuring who in your network provides medications for opioid use disorder, there is absolutely no way to determine if you have an adequate network for substance use disorders. It is impossible. That's a regulation and a statute I would encourage every state to take a look at. And then in the top right there, it's from 2016. In 2016, the Attorney General of the state of New York entered an agreement with Cigna, and there are other payers that they entered this agreement with, to agree to stop prior authorization for across the country. That's an example. Cigna in Colorado, the big red letters, you can sort of see red letters there, they're explicitly saying we don't require prior authorization for substance use disorders. So if payers can do this, this is not difficult. They can do this, and we would encourage everyone to take that action. The Illinois Department of Insurance, this is just one example, but again, they failed to use ASAM criteria as defined by law. And there were other violations there about those non-quantitative treatment limitations that Tim and David mentioned. Here's what I think is important, what Illinois is doing that I would encourage all states to do. They've used the statute to get additional appropriations to hire pharmacy experts, pharmacotherapy experts, the pharmacists, right? The people who know the medications. And they use the parity analysis to look at the actual formularies. And this is a really novel way that states are doing this, both on the mental health side as well as the substance use disorder side. Because medications in many of these illnesses are essential parts of the treatment plan. And if you don't have somebody on staff who can do this, then you're just sort of flying blind. And so these are some of the areas that Illinois has looked at. And then getting even, and Colorado, again, looking deep in here, that not all plans are failing, but most still are. So there has been some progress, but there's a lot more that needs to be done. And then what level of formula review is necessary? And I have this in there because it's intentionally really complicated, but this is the type of analysis that's needed in a state, and so states can do things like use your opioid litigation settlement funds to provide your Department of Insurance the expertise to hire a pharmacy expert. That's the level of expertise needed. And you have the opioid litigation settlement funds to do that. It's not overly expensive. I know everybody wants to use those settlement funds for something. But if you want to have meaningful action, this is one area in which to do that. And that's just a list of the medications that on the level of formulary review that's necessary. Thank you very much.
Hi, everybody. I'm Brad Lerner, and I am the Health Policy Director for Mental Health and Substance Use at Elevance Health, and thank you for having me speak here. I'm going to just pick up on a few points that everybody said. I don't have a slide deck, but I'll be glad to speak with folks after the event as well. Just wanted to give sort of a little bit of counterpoint to the last three speakers. We at Elevance Health care tremendously about this issue. This is a super important issue. And we have done a tremendous amount of work in Parity. Pamela mentioned from the association, but when you look at a health plan, we have, this is not something that we are not being intentional about. We have large internal committees made up of clinical, network, legal, compliance. We have internal governance, and we engage with advocacy groups, trades, federal, state policymakers. But there are these interpretive challenges and sort of disagreements around the NQTLs. There is a subjectivity to this. And we are also seeing some state requirements conflicting with the federal framework. This is a very technical law, and so it's very important, and I think David had mentioned that this is not a panacea for all of the system issues going on with mental health. I think looking at the big buckets of telehealth, access, youth, integration, all of these things need to be addressed, and we have a lot of solutions moving forward, both at Elevance Health and in the industry. But as far as the technical law, the rules are very dense and they're often confusing, and that's why I think you've heard several folks talk about this upcoming rulemaking that the federal government, the tri-agencies, are going to be releasing any day now. We really want, when we talk about the state standards, we'd like those to be uniform with the federal law to make sure that we have sort of a level playing field and understanding. And so that's one thing that I'm hoping folks will take away. And we also have provided many ideas in working with the states on how to improve MAPEA compliance, standardized NQTL examples, model answers, like de-identified examples of compliant documents. Those would save tremendous resources and guesswork on the health plan side. And I do also just want to take the time to address, how personal this is for many of us on the health plan side. That 1 in 5, it's really 1 in 1. We all know somebody dealing with it. We all know somebody I dealt with in this pandemic. My brother dealing with treatment-resistant depression, and one of the things that was tremendous about what we've seen in gains in telehealth is he was able to utilize a virtual IOP as a step down, and that was virtually non-existent, these sort of new developments. So we really have to nurture the telehealth. This is not a parity issue per se. Certainly on the quality side, we've seen a lot of providers, there isn't this sort of bilateral accountability in parity. As you've seen, it's a technical law, looking at payers, but we really want to see, since out-of-network, as Pamela mentioned, must be covered, we don't have a sense of the quality. We see residential treatment facilities for substance use providing healing crystals. Many of the providers themselves do not adhere to the gold standard of medication-assisted treatment. There were some really abysmal statistics coming out of what providers in these facilities are actually using those. So we'd like to see more oversight in that area, and I think that's a great area to partner on. And again, just getting to, network adequacy, provider shortages. These are not MAPEA enforcement issues per se. I think that, there is a lot of work we're doing with including peers, having providers at the top of the license, cross-state licensure. There's a lot of interesting policies that we need to be digging into to help address this. And I think I would want to add at the end here, I just pulled this because Representative Jennett speaking at the beginning, we are putting we have implemented a suicide program at Elevance, and I just wanted to pull this that has been incredibly successful. And basically it uses predictive analytics to reach out to members based on how they're presenting and claims to reach them before they get to that point. And we've seen a tremendous success in this program, and we're starting to roll it out into all markets. We also at Elevance have been specifically intentional about the 988. We are the National Backup Center for Chat and Text. So I think these things don't necessarily get put into a parity analysis, all of these programs that we're trying to move forward and make sure that our members have access to quality care. So I think I'm catching right at the end here, but tremendously more to say. It's a very passionate issue for all stakeholders, and I'm really glad to be with my colleagues on this panel.
Thank you so much, and just a huge thank you to Will and everybody at NCOIL for pulling this amazing panel together to speak to us today. And thank you to the lawmakers who stuck around. I know we pulled the anchor slot here, so the fact that there's so many of you still here means a lot, and same to everybody else in the room. I'd love to open this up to questions from lawmakers. I have a few myself, but if anyone else would like to start, please let us know. Okay, great. Representative?
Thank you. And thank you all for being here today. This is an issue that I'm a physician. I work actually in substance abuse and mental health as well. So I do medication-assisted therapy all the time. So this is something I think is very important. I greatly appreciate all of your testimonies today. As of June 27th, we just had, with medication-assisted therapy, the limitation on how many patients I can see and prescribe Suboxone to lifted, which is great at the federal level. I do know that some states still have restrictions in place. Do you know which states might be doing that or are exploring putting restrictions themselves in, and how can policymakers be aware of advocating for patients to have access to this critical therapy?
Thank you. Thank you for the care you provide. I think some of the restrictions that we see, still have to do with, where a substance use disorder clinic might be able to be established. I agree there does need to be some oversight of some of the treatment facilities, but I would say that is one issue. Some of the restrictions that we see needing to be addressed right now have to do with dosage limits. In some states, as you said, buprenorphine is generally the gold standard for treatment in the community. And physicians report to us that the dosages greater than 24 milligrams, for example, is showing some success in treating patients exposed to fentanyl and using high amounts of fentanyl. Most states and Medicaid agencies, as well as formularies, have a 24 milligram threshold. And so what happens on that quote slide that nobody could read here, but again, it's happy to make it publicly available. There's a quote from somebody, from a patient who tried to get their dosage and was turned away at the pharmacy counter because of that buprenorphine prior authorization of 24 milligrams. And for those of you who have gone through prior authorizations, it's not just a 30-second issue at the pharmacy counter. When patients are turned away because of this 24 milligram restriction, for example, they're probably going to go out and use or struggle and go through withdrawal for a period of time, and putting them at increased risk of death. So that's one restriction that exists in most states. New Jersey is one state that has removed the 24 milligram threshold. They did that in Medicaid, but they haven't done that across the board. Other restrictions that we would encourage states to take a look at have to do with opioid treatment programs. In many states, opioid treatment programs require you to go to the treatment program on a daily basis. There is flexibility in those treatment programs for the clinician, if somebody can afford and is capable of handling take-home doses, to go ahead and do that. But transportation is often a problem to get to an opioid treatment program on a daily basis. Some payers do a great job of providing transportation benefits for patients to go to an opioid treatment program. That's a restriction that it's not really a restriction per se, because if you can get there, you can then it's great on a daily basis. But if this is an area where the state has the opportunity to offer those transportation benefits, it removes that barrier to care. So I'd say just to wrap that up, the medication dosage is an absolute restriction that exists in almost all states, and the transportation access to OTPs is something that we would encourage as a removal of a barrier in all states.
Just as a quick follow-up to that, and to kind of give a little bit of background to people who might not be as familiar with MAT, when we first started doing MAT, with Suboxone, we were limited to 100 patients per each medical license. That's all I could ever do. Until I took one patient off, I couldn't put another one on. So we quickly hit our limitation on how many patients I could treat, even though it was very safe. And then they eventually raised that limitation to 275 patients per license. And then as of 3 weeks ago, that was lifted from the federal level. I was curious, on the state side, because it doesn't actually say that it prevents limitations, so it just lifts the federal requirement. Are there states that are looking at implementing that? Because that would be something I'd be very, very concerned could happen.
I'm not aware of states re-implementing a restriction on the number of patients. I think that would be in direct conflict with federal law. But it is something, I'll go back to, these are questions that payers can and should be looking at when they're contracting with addiction medicine professionals. If you don't know how many patients are currently being seen by each addiction medicine professional in your network, you don't know if you have an adequate network. It's impossible to know.
Thank you so much.
Thank you. I believe Rep. Hefner has a question.
Thank you. Very informative. I keep hearing there's so much more to do. Yes, there's so much more to do. As a parent and a wife, it's difficult when I keep hearing those words about there's so many different pieces that have to happen. And one is that when it comes to sort of a family-centered care, we're left out because of HIPAA, that we can't help. We are not allowed into knowing about that treatment because of patients' rights. When a child is over 18 or a husband, treated differently than a broken arm, or as my colleague from Colorado talks about, heart attack. The HIPAA is different. And I guess my question is there some sort of way that, as a wife, my husband did complete a suicide. There was no discharge for me in trying to figure out how do I help him after he was let out of a hospital. They don't, and then it's just required by statute. When you're in crisis, you don't know what questions to ask. And so it's very difficult. I see all these things with compliance and stuff, but when you're trying to get this help, I think we don't have enough information on how to do it. In-network, out-of-network, in our rural areas, we call numbers and they're not there. So all these pieces to try to help families, I think it maybe has to put the weight not on the family that's in crisis, but more on the insurance companies or benefits programs to say what your rights are and what they're not.
No, thank you so much, and I'm so sorry to hear about your loss. We hear from families all the time that this is an impossible system to navigate, both the treatment system too often, but also the insurance on top of the treatment needs. Often insurance is another layer of complexity and very difficult to navigate. And I think everyone at this table needs to work on improving that system and improving communication with families. There are HIPAA rules that you've mentioned that in the past the Kennedy Forum has advocated for changes to some of those rules. I know ABHW has worked on sharing of information between clinicians. SUD information for substance use disorder information has to be kept essentially siloed from other clinicians. And that has been, is in the midst of being changed. Pamela, I don't know if you want to talk about that.
One quick moment. I just want to make sure that everyone else in the room knows that there is a microphone in the center of the room. So if there are any payers that would like to speak up on this or any of the other questions, please feel free to come to the mic.
Yeah, I completely understand the issue that you're talking about, both from a knowledge point, but also even when you know what can be done or needs to be done, you might not be able to do it. From the health plan perspective, support in trying to get some of those changes made. I mean, you do have to balance someone's privacy, but with substance use disorders, there's a law that's separate and more restrictive than HIPAA, and we led a coalition that I don't think AMA was a member, but Kennedy Farm and psychiatrists were, to try to change that to align with HIPAA, because that also increases, these different rules increase the stigma. Because why should, you probably could find out if your husband had had a heart attack, and on discharge you would get a lot more information than you would mental health wise, or especially substance use disorder wise. So, you do need to protect the privacy. You don't want information to get into the wrong hands, but involving the family is a key component for behavioral health, and health plans do recognize that, and even in treatment involve the family, especially when you're talking about children. It is so important.
And I would say too that yes, HIPAA, particularly for people with mental illness. My first entry into this space a number of years ago, there was something called the Opening Closed Doors Conference that I went to. It was all about, and I heard these brutal stories from families that had adult children with schizophrenia or other serious mental illness that they couldn't. They call it dying with your rights on. So in other words, your privacy rights lead you to your demise. And I think one thing that's very important that I think everyone needs to know about HIPAA, that I think you run into issues with hospitals and other facilities, There is nothing in the law that says they can't listen to you. And you can tell them, you can give them information about your loved one just so they know. These are certain triggers, these are certain issues that I know he or she could be dealing with, just so that can help inform the care they live. Even though they might legally can't tell you, they can't even necessarily acknowledge that they're there, but you know they're there. They can listen to you. That's not illegal. That does not violate HIPAA for them to listen to you say what you know about your loved one's mental illness. And that's something that a lot of times you'll hear they'll say, oh, no, I can't listen to that. I can't. Yes, you can. HIPAA does not prevent them from listening to you. So that's something that everyone should know about HIPAA, is that when you have a loved one with mental illness who may or may not be in a facility, they may or not be treating them, they can't tell you. You can tell them everything that they need to know about your loved one.
We have a speaker. Is it Valerie? Is that correct?
Yeah.
Valerie, would you tell everybody who you are, who you're with, and then please make your
So,
comments?
Valerie Brown with United Policyholders. I'm not wearing my UP hat. I used to be a Chief Quality Assurance and Compliance Officer for a multi-service agency that included an SUD MAT program. And so we're talking about HIPAA, and then we've got 42 CFR on top of that, which makes it even more complicated to navigate. So I wanted to see if you guys could address that piece. And then the other part, when we're talking about mental health, having children and multiple Girl Scout leader for 3 troops, 36. So about 10% of my girls had ADD, ADHD, all of these, autism. And what I saw during the COVID crisis that is not resolved is that they're stuck, their treatments are going backwards because they can't get access to the medicine, because that's that step and fail first that's being held, that standard for the medications. And it's making the situation worse. They're falling into depression because they can't get a handle on that. So those are 2 things I just wanted to ask you.
So I'll take a component of that, the 42 CFR Part 2, which I always say is, so sexy to talk about, but that is the federal substance use privacy law. And up until a few years ago, basically the individual that was seeking treatment for substance use disorder had to sign off for each person that would share the record, that could see the record. So even if we were all a group practice, if all of us were to see it, they would have to write, Pamela Greenberg can see it, Tim Clement can see it. And same was true even for the provider to get payment. They had to say, Elevance Health can see it, which, as you can imagine, well, an administrative nightmare, but more than that, if you were looking at trying to coordinate care, trying to potentially have a family member who's caring for you know about the information, trying to stop people who have a substance use disorder from getting more pills, it was a real roadblock. We were able to get the law changed so that now one signature is required. We'd like to align with HIPAA. HIPAA does not require a signature. HIPAA, they do ask you for a signature when you go to the doctor, but if you don't sign, your information can still be shared for treatment, payment, and healthcare operations. We'd like to have it be the same for substance use disorders. There's still one signature required, but at least once that one signature is required, it can be shared for the appropriate reasons. And it specifically states you can't share it with landlords, you can't share it with employers, other things like that. So there are protections there. So that we are waiting for a final rule on 42 CFR Part 2 right now. The proposed rule was issued, comments were made. So that's one component, I think, of your question.
I think part of the issue too, we do not do sort of a fail first type of authorization for drugs, but this whole idea of when you're looking at the continuum of care, that's what we look at for behavioral health. And a lot of times, having people stay in prolonged stays, artificial environments, we need to get them back home, back into these intensive outpatient, partial outpatient therapies to make sure that they are dealing with the situations, their families, school, their jobs, the stressors. And part of the situation is with utilization management in general is that sort of tension of making sure that they're in the right level of care for where they are in the continuum. And certainly with drugs, you know, with mental health, we would like to see more development in this area, but when you have new therapies, like let's say we've all read about ketamine or psilocybin, you know, just to, you know, there are less probably, you know, I'm not a doctor, but, you know, ones that maybe have less side effects, maybe have less concerns of safety, and there is that sort of tension, you know, in dealing with what is the appropriate level. So it's not about, you know, just saying no to care, but it's understanding the continuum of care and understanding what the right treatment is for the individual.
Yeah, I'm going to hand it to David in just a second, but I want to introduce a term to you guys that David's going to explain more in a second called the generally accepted standard of care. Nonprofit professional medical associations such as the American Society of Addiction Medicine, the American Psychiatric Association, the American Academy of Child and Adolescent Psychiatry, and others, the people, the specialists who you bring, who we all bring, you know, our children to, who we all hope have access to when needed. They all have guidelines. Board specialists, specialty boards require an even additional level of specialty care, and there are standards of care. And it's a policy determination, however. Does a state want to put interpretation of the generally accepted standard of care in physicians' judgment, who have 10, 20,000 hours of medical care, or in the utilization procedures and policies of a payer? That's a policy judgment. I think you can all know where the AMA stands, but that is the definition. But I think it's important to go a little bit deeper on what the generally accepted standard of care is and legislative development in this area.
Yes, thank you, Daniel. And this is an important area over the last few years. There's been an important court case, which I won't get into the details of. Suffice it to say that across the country, broadly speaking, there is no requirement that health insurers make medical necessity determinations consistent with generally accepted standards of care, which we think is a real problem and have been trying to solve. And we also think that it's really important to make sure that we're aligning our system, both for providers but also payers, around common standards of care, like the ACM criteria, the American Society of Addiction Medicine criteria, which a number of states, you know, have requirements that payers use it. They use these criteria when they're making their utilization review decisions for substance use disorders. And so putting in place that common standard can be very, very powerful. A number of states have done it. California has done it. Illinois, Oregon, New Mexico, a number of other states tie substance use determinations to the American Society of Addiction Medicine guidelines. United Healthcare, the largest insurer in the country, has voluntarily moved to using the ACM criteria, the level of care utilization system. So it's our view that every payer should be using these criteria and that no medical necessity determination should be inconsistent with what are the accepted standards of care among clinicians. So we think this is very important. They're pretty common sense standards. We have something called the Ramstad Model Act, which is actually named after former Congressman Jim Ramstad from here in Minnesota, who unfortunately passed away a couple years ago, but it was the author of the Mental Health Parity and Addiction Equity Act with Patrick Kennedy. So that's you know, something states can look at in putting in place you know, requirements that you know, can be quite powerful.
You know, this is a perfect example to come full circle with Parity, because on the medical surgical side, most payers and most are using something called Milliman or NCOIL, different criteria. And so to have, it's actually in perfect parity to use the same criteria on the BH side. And I think that to the extent that the generally accepted standards of care, we've had a lot of differing decisions on that. We do use ASAM criteria, but as far as there are a lot of gaps with some of these criteria that have been discussed today, and I think the idea, you know, just when we look at parity, not only the 42 CFR issue, but the IMD exclusion, which is sort of a mid-level standalone residential treatment, that is not allowed for mental health and substance use, but it is allowed in physical health. But when we say, oh, you should cover that, we're told that, that's exempt from parity, just as 42 CFR, let's have the same privacy standard. That's exempt from parity, the criteria. So it seems like there are some things that are not actually looked at from parity that might be useful. So again gets complicated in looking at that. We do use the same criteria that we do on our physical health side that we do on the mental health and substance use side.
In the interest of time, I'm going to move us on. First of all, I would like to say, Rep. Hefner, thank you so much for sharing your story with us. I'm so sorry for your loss, and I'm impressed that you would make that offering to all of us so that we can move this conversation in an even more healthy way, so thank you. Rep. Bennett, I believe you had a question?
Okay, wow, her question should have been the last one. Mine's pretty boring, but Ms. Greenberg, you actually mentioned the proposed rules and that the comment period is happening from the Biden administration regarding parity and payer reporting. I'm just wondering if you all have opinions about the proposed rules that they've put together, what you think of them, if they go too far, if they don't go far enough.
So we have not yet seen the MAPIA proposed rules. I mean, obviously there were final rules that we're have been living under for many years now. We are waiting for the proposed rule to come out, and we think it might come out in the next few weeks. I don't have a sense of what will be in there. There are things that we're hoping will be in there that we're asking for, and most of it is around getting more clarity for this NQTL analysis. We have asked them, can you give us sample analyses? So kind of like, what does the A paper look like? Because in the report over a year ago, it said that every plan was insufficient in the information that they provided for the audit. Well, if everyone is insufficient, the example we like to use is if there was a test and every student failed the test, you wouldn't say every student isn't smart, right? You would say, what happened? Was it dark in the room? Was the test not written with good language, right? There's something else going on there if everybody doesn't do well. And so with every plan not submitting the correct information, not that they failed, not that they weren't parity compliant, there wasn't the right information for the regulators to even know whether they were parity compliant. So we say, because of that, give us more information. Show us what compliancy looks like. So when we're doing it, we can say, okay, we have these 10 documents. They want these 10 documents, we have them. Also makes it great for states when they're doing an audit because they can say, look, we told you these 10, where are they, right? So it would help everyone. So that's one thing we'd like to see in the proposed rule, or maybe it comes afterwards, but that they're going to do that. We also would like to have an appeals process. I mean, appeals process exists all over, so if we think that from a plan perspective, yes, we were in compliant, you don't think we were, there should be some kind of appeals process. Those are two of the things that we're looking for in the proposed rule. I don't know whether they'll be there.
Thank you, and I think our last question here will be from Rep. LaBeouf.
Great, thank you very much. So, and I'm sure all of us, across the country are experiencing the provider shortage, and something that's going on in my state is we're seeing trends of some providers, because there is such a shortage, having the liberty of either being completely private pay or dropping particular plans because of the difficulty of working with them. Or on the other end of the coin, we're seeing providers that are trying to accept a particular plan are being held up for months in regards to actually getting access. So I'd be interested in hearing from all of your geez, I'm really messing stuff up. On hearing from your perspective on, what are each of your associations doing to address this, and what recommendations can we take back to our own communities?
We're just each gonna take the mic down the line. For our member companies, again, health plans, there's a lot being done to try to increase access because the workforce shortage is very, very problematic. Many plans have, I know reimbursement was mentioned, many plans have increased reimbursement to try to get more providers in the network. That doesn't necessarily create more providers. So there are also things like the collaborative care model, which is an integrated care model that's the primary care provider's the lead with a psychiatrist as a consultant. We support that, we pay those codes, we encourage primary care providers to get into that. It's a way of having psychiatrists practice at the top of their license. The other thing is there are some companies that are cropping up that are basically big networks of providers, and they will do the credentialing for the provider. They basically work with the health plan, so the provider doesn't have that administrative burden. So the providers like to be in that network because they don't have the administrative burden. And the plans are contracting with those companies, so they have a large network of providers available. Those are a couple of things we're doing.
Yeah, I just want to echo that Pamela just mentioned the collaborative care model. That's integrated care. You go to primary care and you can get behavioral health care integrated within that collaborative care, highly evidence-based. I strongly recommend you look into that. That's something where providers and payers, at least for psychiatry, we really agree. But one thing you mentioned about the credentialing piece, there is, and this is not something I think Pamela or Brad would like to hear, but there are legislative approaches you can take on that. In fact, I just drew up a bill for a legislator in a state I won't mention this week, but you can basically establish that credentialing has to happen, like a decision has to be made, yes or no, within this time frame. And whatever you want, 60 days, 90 days, whatever you want it to be. And then if the decision hasn't been made by the time that you've gotten to the limit, then the provider is automatically can submit claims and be reimbursed at the in-network rate, the standard in-network rate. That doesn't mean they're part of the network yet, because that could create some legal issues, but they automatically can get in-network reimbursement until the decision is made to approve or deny. So even if they end up being denied, it's like, no, there's reasons we're not going to credential you. Like, until that decision is made, they get the in-network reimbursement rate once the time limit has been eclipsed. So that's something the New Mexico passed a law like that recently. So that's something that I know some other states are looking at. So you could definitely do something like that.
I don't know that I have too much to add. There certainly are things that states can look at in terms of Medicaid reimbursement rates that are important too, in terms of, because Medicaid network adequacy is often, in many instances, worse than commercial insurance, and a lot of that has to do with the reimbursement rates that state Medicaid agencies and Medicaid MCOs are paying.
Yeah, I'll echo, credentialing, the processes and the ways in which payers credential is also an aspect of parity analysis. So that is an area that your regulators can look at. Contracting and increasing rates. Virginia has done a great job in through their behavioral health agencies of increasing rates and reducing barriers. Those two things are really essential. Increasing rates, reducing barriers. They built the network in their Medicaid agency for substance use disorders. So that combination is really essential. And another thing I think to increase, you don't hear about provider shortages, for cardiologists, right? And cardiovascular surgeons. This is just an area of will. Again, I'm not saying it's necessarily easy, but cardiologists and cardiovascular surgeons do get paid a lot more than addiction medicine physicians and psychiatry. And so this is an area of it's policy, and it can be done with the appropriate legislative encouragement. And then a third area, again, I mentioned opioid litigation settlement funds. To build a more robust network of psychiatrists and addiction medicine physicians and family physicians and primary care physicians, you have to train them. And to train them, every one of your states has academic medical hospitals. Hopefully there's, a mental health or a psychiatry or addiction medicine and primary care in those hospitals. Those opioid litigation settlement funds can be used. You can appropriate money to them specifically to hire core faculty in psychiatry and or addiction medicine. If you hire core faculty, you can train, you can build them into the rotations, into the clinical rounds, and you can demonstrate that treating patients with mental illness and substance use disorders is incredibly rewarding. And so that helps build the next generation of that specific area, for your state. Most people who train in a state tend to stay in the state. So if your state invests in that area, you will have invested in ongoing generations of those specialists.
I love that idea about the opioid funds. That was very educational. One thing that I had mentioned earlier, but that we really are leaning into, is figuring out peer supports and peer coverage and better use of peers, people with lived experience. There's evidence-based treatment that they are a crucial part of the recovery. We have a lot of innovative peer programs. Unfortunately, the Medicare program does not reimburse for peers, and there's a bill before Congress that has come up before on that called the Promoting Effective and Empowering Recovery Services, the PEERS Act, that ABHW has supported. But I think that, to Pamela's point about looking at the top of the license and trying to figure out which, having different providers being able to expand the type of licensure types. And again, we haven't spoken much about telehealth, but that has been just this incredibly important piece of the access story. And we want to make sure to protect different abilities for members to get the treatment where there have been some federal rules that have changed, but there are others that still need to be changed. And I think states can continue to work to make, whether it's through licensing pacts or the otherwise, to really make sure that there's a robust telehealth system in place. And finally, increased funding for graduate medical education programs, loan forgiveness, different ideas to build the workforce. That obviously doesn't happen overnight, but we've been incredibly supportive of that as well. Thanks.
I'm going to just add to the answers based on 2 points you made. One is reimbursement rates, one is telehealth. We started in Colorado free telehealth for any school-aged youth that wants it. Any school-aged youth that wants it. We're paying right now out of the general fund, and our reimbursement rate is such that we are getting people who don't take Medicaid and don't take private insurance. We don't have a network adequacy problem. We have a reimbursement problem.
Again, thank you all. I had one question that I wanted to ask, but we don't have time for it, so I'm just going to sum it up. I love repetition. So, I will say that I put the bill that Representative Michelson-Janae put forward in Colorado and that I'm putting forward here in the back as a starting conversation for us. I am very open to having further conversations on that. I just want to, I hope that we would come up with some solution ideas or some areas to focus on. So things I heard you say we could take back to our states and start working on are reimbursement solutions, behavioral emergency coverage, parity, eliminating step and first fail policies, transportation benefits, encouraging provider training and building core faculty, using those opioid funds for those things, and then also perhaps hiring state specialized pharmacists to help us oversee in these areas. So I think we all have a lot of food for thought to take back to our states. I am again so grateful that you came to speak with us today. Thank you to NCOIL and everyone, and thank you for a great conference. Have a wonderful day and safe travels, everyone.